So we should be good to go there. And so the format today is pretty straightforward. Each speaker is going to have 10 minutes to present on an aspect of our overarching theme of overcoming barriers to dementia care from their own professional lens. And then we'll do a quick 2-minute Q&A for each speaker once their time is finished. And after each of our 4 speakers have presented, we'll have a fuller 10-minute Q&A for the whole panel if there are lingering questions. So, and just to remind you, if you do have questions, just pop them in that chat box. And when it's time for questions, I'll pull them and direct them to the right people. So now let me quickly introduce our panel of speakers and we'll get started. So first up, we have Dr. Elizabeth Sutherland. Dr. Sutherland is a geropsychologist who's been practicing at the San Francisco VA healthcare system since 2007. She completed her residency at Mount Sinai School of Medicine of New York University and postdoctoral training at the San Francisco VA healthcare system. She's an adjunct faculty member at John F. Kennedy University and has a thriving private practice throughout the Bay Area. All right, and then we've got Robert Rossborough. Rob is a mediator, lawyer, and professor. He specializes in mediating family conflict, frequently over caregiving decisions. He's also an estate planning lawyer as of counsel to Monty White LLP. He's president-elect of the Marin County Bar Association and a graduate of Yale and Stanford Law School. Hey, Rob. Okay, next we've got Tammy Anastasia. Tammy's a dementia consultant and educator. She has a master's degree in counseling and certificates in gerontology and end of life. Tammy has a dementia consulting practice in Los Gatos called TAMS, Alzheimer's and Dementia Support, and she provides one-on-one caregiver support, guidance, and care strategies. In addition, Tammy facilitates 5 local dementia caregiver support groups. She's partnered with Elder Consult and provides monthly caregiver educational workshops. Hey, Tammy. And finally, we have Paula Marks. Paula has served as Vice President of Care Partnerships for Tender Rose Dementia Care Specialists after joining the company in 2016. In her role, Paula works closely with families of individuals with dementia to educate them about Tender Rose's services and approach, as well as other community and care options that might be a good fit. Paula came to Tender Rose after a long career devoted to helping others in both the public and private sectors. She holds bachelor's and master's degrees in criminology from Simon Fraser University in Burnaby, British Columbia, Canada. Hey, Paula. All right, so that's your panel, and we're going to go ahead and get started. So up first, we'll have Dr. Sutherland, and she's going to be addressing the changing nature of sexuality and intimacy within a relationship between a spousal caregiver and a person with dementia.
Thank you. Hello, everybody, and thank you very much for inviting me to speak today. This is a very important topic because one of the things that we learned growing up from childhood is to build relationships. And one of the things that we do throughout life is that we build new relationships constantly. And I always tell my students, and I teach the human sexuality for licensure for psychologists for the state of California, there's a study where you take college men in their first or second athletic, vibrant college men, you give them a clicker and you ask them, you say, when you think about sex, click, click, click. And it's about every 15 or 20 seconds. Interestingly enough, that really doesn't decrease as one ages. So you fast forward into somebody who's in their 60s, 70s, 80s, and 90s, more so with men, they're going to be thinking about sex. Now, go the other route with the medical ways that we've been doing. We're doing a phenomenal job of keeping people living longer. We're doing great things with the heart, the kidneys, the livers, the everything. The brain will atrophy, will always atrophy. So you may have patients where it's not uncommon now, in the 30 years I've been around dementia, it's not uncommon now to hear somebody who has Alzheimer's for about 10 years and they've been declining for 10, 12 years. It's not uncommon to hear about somebody who has Parkinson's disease that was diagnosed about 20 some odd years ago. And it's not uncommon with the Parkinson's people that cognitively they're still somewhat intact compared to those who have the Alzheimer's type of dementia. So with that, what I'm noticing in the past about 10 years, 30 years ago, I used to hear, 20 years ago, I used to hear, oh, we have a wonderful caregiver. They're just like our granddaughter, or they're just like a daughter or a son. They're wonderful. Now I'm hearing, because the field has really blossomed with because older adults, as you know, is the largest population. I'm hearing more of relationships that are transpiring. And I'd be interested to hear also if you are finding this too. So like, for example, if there's a patient with dementia, either with cognitive problems or no cognitive problems, when they bring in a caregiver, and I'm seeing also more men. So let's say for a male patient with dementia and his wife or spouse or partner is taking care of that person, their relationship has shifted from the time of diagnosis, possibly. The intimacy is shifting. When the caregiver takes on that role of caregiving, as the patient is progressing, they might be taking on more aspects of issues with incontinence, issues with role reversal, taking care of the household, taking care of everything, having everything on them and the stressor, and being the number one person now. Also taking care of, I'll hear a lot of people say it's like taking care of a child, although that reference sort of, I hear it, I don't necessarily kind of agree with it, because you are talking about an adult who's lived a long life with a particular personality. But with that being said, the relationship starts to shift drastically. Now, the patient with dementia may want to continue that intimate relationship. And I do a lot of couples therapy around the fact that the relationship has shifted. The intimacy for the caregiver somewhat has taken away, put on the back burner, and they may sit there and say, I don't even think about it. It's not even entering my mind. And then also the physical component, they're having a hard time feeling that type of intimacy toward the person they're caring for, because they have to take care of certain things like the bathing, toileting, feeding, and they're just having a hard shift with their mindset to be intimate with this person now that they're taking care of. So now in comes possibly a caregiver. I have a few, probably a handful of cases right now to where there's intimacy transpiring with the caregiver and the partner caregiver, and then the outside caregiver coming into the home. Because all of a sudden that person's coming in, they're validating the spouse, the partner, they're validating their loss, they're having somebody to talk to who they can communicate with. With COVID, sometimes they're in the house 24/7. And for many, many months, they've been under the same roof for a very long time, building that relationship. I've seen it both ways, where if the patient is a female, I've seen it with the male caregiver when a female comes in, or a male. It doesn't matter on the gender. It's somebody there who cares for them, who's very open, who can communicate and validate. And so I'm seeing a lot of these relationships shift. Now, of course, when in therapy, whether I'm doing couples therapy or I'm doing individual therapy with the partner who's going through this new relationship, there's going to be a lot of guilt. There's going to be also cultural implications, religious implications, family. What are the kids going to think? What are the grandchildren going to think? How are they not going to know there's something going on if they're interacting with that family? How are they not going to know that mom or dad is kind of acting kind of differently? The other component is, as I mentioned, like religion, ethnicity. There's so many aspects to the therapeutic relationship with the spouse partner. but especially their feelings of guilt for even thinking about intimate thoughts about the caregiver, or even taking part in an intimate relationship because of vows that have been taken. So I've got one couple who, long history of Parkinson's, cognitively intact, was open to his wife having a relationship with the male caregiver, wanted to be a part of it. And unfortunately, they tried it. It's more of a voyeuristic type of approach. He wanted to be a part of it. Unfortunately, the husband couldn't really take the feelings of his wife being with somebody else. So the deal is that they would stop. If somebody was uncomfortable, they would stop. Now the caregiver has got some religious components of his own, married, they're 24 hours because of COVID, and then the wife, so they're still kind of continuing the relationship, and now the guilt that the husband doesn't know. I mean, it's very triangulation. It's triangulated, as we know, and it's in the home. And COVID, as far as we're saying at the VA, we're going to sort of be in this bubble till about this time next year. So I'm seeing a lot of relationships shifting and a lot of dynamics shifting. And with the holidays right now, it's bringing two things front. One is, if family is coming in, they're seeing dynamics being changed. You know, if you're feeling, you know, those, if the wife, spouse, partner is feeling those feelings of intimacy with somebody else, when family comes into that household, they're going to realize something's going on. They're going to see something's going on. So it's this holiday season, I have to say, is very challenging, as I'm sure all of you are seeing with people who you're taking care of. And it's a dynamic that unfortunately is going to be in place for about another 10 months, we're saying. So it's important, I would say, as when I walk into the house, so for me to pay attention to all the dynamics and where each person is with regard to their ethnicity, their religion. Sorry, this is working at home with my dog. So I really take a look at, you know, where's the family system? What are their dynamics? What are their beliefs? What are their values? How open are they? How not are they? Where are they standing? But with all the dynamics involved, so that I get a good understanding, because it's not about me and it's not about my values. It's where are all of you right now, and then who knows what and who doesn't know what, and you're trying to juggle everything. So it's peculiar times. It's fascinating, but really it's relationships.
It's relationships.
And every aspect of our life, we are, and I'll end here in a second. Every aspect of our life is about relationships. Everywhere we go. Absolutely. And so it's really important work that all of you are doing in the home. And it's evolving. Everything's always evolving. And I'll kind of end there.
Thank you. I know that we could probably talk about just this specific piece for hours, right? We are at time, but we did get a quick question if you would like to address. How do you handle indications that sex between a spouse and their demented partner is non-consensual?
That goes into capacity evaluations, and as psychologists, we do capacity evaluations. And one of the main aspects, so it's about, you know, do they have the medical decision-making to make medical decisions? Do they have the decision-making component for financial? And also, do they have the mental wherewithal to be involved in an intimate relationship? Can they be in an intimate relationship? It happens a lot in care homes, in SNFs. There's a lot of sexual relationships going on. But it's something tougher not now. But it's something that you may have to bring in somebody to assess it. If they're married, it could be very different if there's abuse going on. And then you're looking at like an APS report type thing. If there's abuse.
Right.
But I do have patients who still, like caregivers who do, partners who are still wanting an intimate sexual relationship with their husband or their wife who may have severe dementia. And they've been together for 50 years or even less than, or 10 years or 5 years, but they still want to have that intimate connection. So it all depends on the dynamics and what's going on.
Great. Thank you so much, Dr. Sutherland.
Welcome.
All right, so up next we've got Rob Rossborough. So Rob's going to be discussing tips for communicating with a caregiver spouse that will increase the likelihood of both patient and spouse accepting care. So Rob?
Good morning, everybody. So I think Amanda mentioned that one of the things I do is practice law, and the first thing I'm going to do here is essentially denigrate how the legal system resolves conflict, and ask you, if you take nothing besides this away from today, don't model your interactions on the legal system. What most people tend to do when you come in and a spouse is resisting the level of care that's needed, and you say, well, this is what's needed, this is why, and here are all the great reasons that we need to do this. And this doesn't work. Marshaling your evidence, you can go on for days, and just as a general rule, that approach to convincing someone doesn't work. And part of the reason is that we're not rational actors. I mean, the law has long assumed we have a pros and cons column, and we can add up each one, and that's just not how we work in making decisions. And certainly emotion plays a huge part in our decisions. And I think particularly in this situation, a spouse is going to be in some stage of grief about the relationship, and their energy may be focused to varying degrees, potentially a lot, on what they themselves have lost and are losing here. And it can make it extra hard for them to hear what you're saying. I think there's been coverage in the media recently about voting and voters, and that we become so enmeshed in our political identity that we don't even hear facts anymore. We just, we're not persuadable on the basis of facts. So if that's the case, what do you do, right? And so the number one thing to remember is ask questions. So people need to be heard before they can hear you. So just keep asking questions. And so how do you go about doing that? I think in this situation, you just start asking the spouse about their history with their spouse. And certainly for home care, ask them about the home. And, did they move in together? How long have they lived there? What's it been like? And you can ask them to talk about their spouse and about their history and about the beginnings of their dementia and what's changed, what's been challenging. And you'll learn a remarkable amount. And in addition to allowing the spouse to be heard, you're creating trust between that person and yourself. They're much more likely to hear what you have to say if they know you care about them and that their welfare matters and that you're there, you're going to consider their welfare, and that what needs to happen needs to work for them too, and not just the dementia patient. So when you ask questions, I think the number one thing to remember is it really has to be with genuine curiosity. You can't fake this. You need to actually care what the spouse is going through, what they're doing, how they feel about what's happening. And I would say, don't make assumptions going into it. If 95% of your dementia cases have been a certain way, sure, you can have that in your mind, but don't go in with your own assumptions where the spouse is going to think, oh, well, that person thinks they already know what's happening here. You really have to allow for the possibility that this could be different, and it will be different in some ways. Certainly, the spouse is a different person, and you want to find out how they really are feeling. So this can be hard advice to follow. I think the biggest reason is it takes a lot of time. You really can't rush this approach. You have to have a real conversation. And if you're really trying to get on to your next task, or you just have to keep going and have to really spend the time to create that relationship with the spouse and to keep asking questions. And I think here, one thing to keep in mind also is that, not all spouses have good relationships. And, one can still be caring for one's spouse in the home and be in an unhappy marriage or an unhappy relationship. And don't pretend that doesn't exist, and don't ignore it, because that is likely to cause even more grief for the spouse, because they are feeling even sorrier for themselves about what's going on and are more likely to be caught up in their own feelings. And so I think it takes even more work to get through to them in that case. And so I think it's when that's going on, you need to make it even clearer that you're asking about their needs and not just the dementia patients. And so I think asking, at some point, you can ask specifically about the spouse's needs. And, a lot of times they're not really aware of specific needs. And I think just the conversation is likely to bubble some things up to the top. But, they might say, be used to going for a walk every morning at 7 o'clock. And if the shift change is at 7 a.m., that can be a major problem for them. And something as simple as the caregivers coming half an hour later can make a huge difference to them. So just keep an open mind about what can be seemingly little things like that. And so I think just exploring how they feel is likely to get to what some of their needs are going to be. And, whether that's alone time, whether that's, I don't know, it just, there are all sorts of things. And I think it's really important to not make it all about the dementia patient. And so if they've been resisting what needs to happen, when you're asking questions, the thing to do is to not be a problem solver yourself, at least not aggressively, but to talk about how things work. And even if you think, I think I know what I should do here or what's going to happen, always do it in the form of a question. You can ask leading questions if you're skilled at it, so that it's not like obvious that you have a particular answer in mind and that's what you want. And so you really work with the spouse to come up with something that works for you, for the care, and for the spouse. And one of the drivers of spouses' resistance can be just, they're feeling a tremendous loss of control over the relationship, over what's happening in their own house. And there can be a lot of fear that if they agree to something, they don't have control at all. anymore. And so I think providing them with a sense of control, that this is an ongoing process, that things can change around, that they're not giving up control permanently if they even say yes to one thing. And so I think you also have to be creative, because maybe the dementia patient has a very particular nutrition requirements, and having meals together has been a huge part of the spousal relationship. And maybe the dementia patient was a cook, and so figure out a way that the dementia patient can have the meal they need, the spouse can have the meal they need, in a way that more resembles what they had before, instead of, say, bringing, plastic containers of a special meal and having the dementia patient in their bedroom eating out of plastic containers. So it's about figuring out, what can we do that might not be what we expected, but that really satisfies the spouse's needs. And in any conflict, you're trying to figure out, what does the spouse, what does someone want? What are their needs? And you're never going to resolve it without satisfying at least some of their needs. That's basically true in any negotiation. I mean, you don't go into any negotiation and think, well, everyone usually thinks I'm going to get everything I want, and I'm going to be this great persuader, and they're going to come around and see how, why I'm totally right. And it doesn't happen that way, right? So you need to be creative about finding things that you can accept that they need, and work them in together with what you need to have happen for the care. And so I think it's good to keep in mind that, keep coming back to how everything you're talking about affects the spouse and not just the dementia patient. So you're always attuned to what they're needing. And I think, it will continue that building of trust, that you're not coming here to overrun what, the spouse has been doing for years, and that, the spouse is coming from a point of view, hey, I'm hiring you. I'm in charge, right? Like, I get to say what's happening here. So, that makes it pretty important that you have to figure out what they want and somehow make what you want work together. And it's an iterative process, right? You keep asking questions. You're like, well, gee, that didn't work. What would work here? And ask questions. And, sometimes you get stuck. And I think anyone, as with a dementia patient themselves, one of the keys can be a gradual ramping up of what's needed. I mean, I went through that with my own mother, who was very resistant to care. We wanted to keep her in her home. She had Alzheimer's. And you can just start off with something. And might that make you nervous because it's not the level of care that you think should be happening right now? Yeah, sure. But if the alternative is that you don't even get into the home, it's better. And you can work on, well, okay, what's most important for the care here? Or what can I make happen here? And what can I get the spouse to agree to? Change is hard for everybody, and more change is harder. So if you can start with something that's less intrusive, that's less change, I would say go for it. And, you can, in a conversation with a spouse, you can maybe make that happen, keep going with the questions, keep saying, well, and, maybe you just, for a day, you need to be like, okay, I think that's as far as we're going to get today. sometimes you just have to realize that, okay, I'm not going to solve this all at once.
Right.
And so keep building on that relationship and that trust,
Yep.
and keep addressing what the spouse needs.
Absolutely. I think we're at time, but I think you're so right, Rob. I think we're most successful when we use an incremental approach, not trying to tackle everything right out of the gate, but let's kind of build on, each little success, and then we're kind of on our way to really making a profound difference. So thank you so much. I did have one quick question that came through the chat. Let's see. This is sort of erring on the side of, if you're encountering resistance, but it's starting to feel potentially like abuse or neglect on the part of the healthy spouse. What's your plan of action there because I'm sure you've encountered that probably.
Yeah, I mean, I can't say that there's a particular plan. I think for one thing, it depends on what kind of abuse it is. I mean, is it just wanting to isolate them? I mean, which tends to be a part of all abuse, right? But if that's really what their main thing is, that may be different from thinking, wow, that they're being physically abused when someone's not there. So obviously, many people have reporting requirements. Lawyers and mediators don't, actually. Yeah, and in fact, lawyers, it's prohibited, essentially. And I have it, when I mediate, I have it part of my contract that I can report if I really see something that no one else is dealing with. But so I think one thing is you have to be aware enough to know whether this is a problem that's solvable within the relationship, or whether, this is a kind of abuse that, this person is not going to change, and someone external needs to come and deal with this.
Mm-hmm.
And that obviously creates a very different dynamic.
Mm-hmm. Great, thank you.
So if you think you can shift them, keep talking, keep asking questions.
Mm-hmm. Yep. Thank you so much. We're going to move on to Tammy Anastasia. So Tammy's going to be discussing resistant behavior mindsets, and provide some suggestions on how to deal with resistant behavior when it occurs with the spousal caregiver. So Tammy?
Okay, I'm going to share my screen because I put together a PowerPoint for this. So let me get this set up. Okay, are we all good?
We can see him. It looks great.
Okay, great. Welcome everybody. Thank you for attending today's webinar. As Amanda mentioned, my name is Tammy Anastasia, and I am a dementia consultant and educator. And today I'm going to discuss resistance as how it pertains to the spouse that is caring for a loved one with dementia. And I'm going to try to help you understand why they may resist asking for outside care or support, so you have a much better understanding of what the spouse's position might be. So I'm going to begin my presentation by discussing what resistance is and go over some key principles that I'd like for you all to remember. Resistance is a part of human behavior. We all experience it, and we'll experience it for different reasons and different times in our life. But you need to know it is part of being human. It's part of our emotional makeup. Resistance is also a subconscious defense mechanism that gets triggered to protect us, either emotionally and or physically. When we're dealing with resistance, you need to know we're tampering with people's coping mechanisms, things that they've relied on, ways of dealing with life that keeps them or gives them a sense of control and some independence. Spousal resistance is often mistaken for being difficult, stubborn, or uncooperative, which is really unfair to the spouse, because really what the spouse is trying to do is survive the devastation of how this disease has affected them, their life, their relationship with their loved one. So we need to be a little more sensitive and understanding as to what the spouse is going through. And you need to know resistance always serves a purpose, and it can provide us with some valuable and really important information. So when we're dealing with spousal resistance, you need to keep in mind that it's a complex and an emotionally sensitive issue. Next, I'm going to talk about what are some of the mindsets that trigger a spouse to resist outside care or support. So, embarrassment. The spouse may resist asking for help because they don't want to put themselves or their loved one in a position in which they're going to look bad. They want to protect their loved one. They want to protect themselves from putting themselves in a position that could reflect badly on them. Denial is another mindset that's going to trigger resistance because the spouse may think, you know, things are okay, I can manage the care, and they don't see the need. Guilt is another big resistant mindset because they don't want to let their loved one down. So they may resist bringing in care or additional support because they don't want to disappoint their loved one with dementia. And I see a lot of people in my support groups, in my private practice, they feel very strongly that asking for help is an admission of failure. So we have to keep these things in mind when we're dealing with the spouse and resistance. Remember, resistance always serves a purpose. So privacy, I would say across the board, that is a consistent mindset. They don't want strangers in their house, so they're going to resist bringing in outside care. Marriage promises and vows. So many spouses want to honor their loved one's wishes. They don't want to go against it, and they want to see how far can they go to fulfill the promises and the vows they took when they got married. Loss of control, another major issue. So with the spouse, there's two kind of overlapping things there. The spouse does not want to be replaced. A lot of times they don't want people coming into the house and then they get replaced. And the other issue with that also is that they worry that people won't do things correctly. And correctly is according to how they think it needs to be done. Then we have the spouse also will resist bringing in outside care or help because they are afraid of making things worse. One of the things I hear in all my support groups, in my private practice, is I don't want to upset my loved one by bringing people in. So this is a major concern for them, which we spend a lot of time talking about how we can do that. Cost, you know, cost is an issue regardless. Cost is I can't afford it or it's too expensive. But you know what? Cost doesn't become an issue when we can help people see the importance and the value of what we can provide. And then grief and loss is huge. And Paula's going to be talking about that. So I'm going to let her elaborate on how grief and loss plays into resistancy in wanting outside help. I do want to go on the record though, and I need to say that neglect is elder abuse. It is not resistant behavior. And neglect in and of itself is a whole different ball game, which I won't go into now. I just want to go on record saying neglect is elder abuse, not resistant behavior. So we have all these mindsets playing out, and the elder care professional is like, oh my gosh, how do we deal with it? So my approach and my philosophy is we embrace the resistance. And how do we do that? First and foremost, we have to build trust. We have to establish an alliance with the spouse. We need to meet the spouse where they are at emotionally. And then we need to ask reflective, open-ended questions. A lot about what Rob just said. We have to ask the questions. We need to know my goal is to try to understand and put myself in that spouse's shoes. So I'm going to ask certain questions so I can gather the information I need to truly understand where is the spouse coming from? How does the spouse feel? How's the spouse being affected? How do they feel when people suggest getting outside support? Are they even open to the idea of getting outside support down the road? But the number one question you have to ask the spouse every single time you talk to the spouse is, how are you doing? When I'm in my support groups, in my private practice, I cannot tell you how many times the caregivers will say to me, you know, people don't check in and ask how I'm doing. They always ask how the loved one is doing. So if we're trying to establish and build a relationship with the spouse, the key is to ask the spouse, how are you doing? Because you know what? That changes on a dime. That changes so rapidly. Don't assume because they told you one day that it's going to be the same the next day. Don't assume because you talk to them in the morning, it's going to be the same by the afternoon. So whenever you talk to the spouse, show a genuine interest and want to know how they're doing. Then we have to acknowledge and validate the spouse. We need to communicate back to the spouse that we understand and we hear what they're going through. The spouse needs to be heard and they need to be understood. And then another really important thing to do is I want to collect the history on the relationship. I want to know as many details about that relationship pre-dementia. And now I want to know, how has that relationship shifted because of dementia? So one of the best ways to do this is what I call spousal reminiscing. So I get a history of the relationship. What were their roles as husband and wife, father, mother? What was their meeting like? How did they meet each other? Do they like each other? Did they like each other? So there's so many dynamics. I want to get as full of a picture of what those dynamics were. So I have a really good understanding of what it was compared to now what it is. And then once I can nurture the relationship and I build that trust and I've established that nurturing, then my goal is with the spouse is to come up with a list of what I call indicators or markers that would justify now the need for help. So some indicators, markers might be their loved one starts wandering, incontinence, the loved one now is refusing any help. It's getting more difficult to bathe them. It's getting more difficult to help them with the toileting. And this list is individual. I do this list with every single spouse, but it's all going to be individually tailored according to what their needs are and what is their limitations, what is their breaking point. And what's so nice about these indicators and these markers, now we have justifiable, concrete reasons to now accept and be open to bringing in more support. And also you want to be very, very sensitive to how the spouse deals with the word help. You may want to substitute the word help and call it support. Not everybody has a reaction to help, but you kind of really want to listen to what is more receptive to the spouse. What are they more open to hearing? If help is a turnoff, then replace it with the word support or maybe care. Care kind of goes 50-50 too. And then you also want to, what I call, avoid shooting on the spouse. If you want to keep them resistant for as long as possible, then continue to shoot on them. Do not try to do everything in your power to stop shooting on them. And then, as Rob pointed out, Dr. Sutherland, this is a process, and we need to be incredibly patient, incredibly respectful, compassionate, and understanding. So in closing, I want to go over 3 really key points, and that is, when we're dealing with spousal resistance, it is a process, and it's going to take time, patience, and understanding. And you need to know from the spouse's perspective that accepting outside support is a difficult and heartbreaking decision for them. And I do 5 support groups right now. I have a private practice. Majority of my practice and the support people are either going to be adult children or they're all the spouses. And I cannot tell you how incredibly heartbreaking it is for them to have to make this decision. Now, for as difficult as it is, and as heartbreaking as it is, you know what they'll also say to people in the group once they've done it? I wish I didn't wait so long, or I wish I would have done it sooner. But you know, the reality is this: people only know what they know, and we have to honor and respect the process that they're going through, because this has been a devastating, life-altering event for them. And then my goal as an elder care professional is to nurture the relationship with the spouse and then help facilitate their process of accepting outside support. So thank you, everybody, for inviting me. And I hope some of this information I shared with you will be very beneficial to you and what we can do to help these families survive this devastating journey.
Absolutely. Thank you, Tammy. That was just really, well thought through. And I think you gave some really actionable tips and insights that people can take away and use, with the people that they're working with. So we did have one quick question that came through, and this was about just the difference between denial and resistance. I don't know if you can speak a little bit more to that.
Yeah. So remember, resistance is going to be a subconscious defense mechanism. Denial protects us. I truly feel we have to respect. Now, let me say something. We also have to consider safety an issue. So let's assume right now that safety is not an issue. Denial is protecting that person. They're not ready yet to deal with the emotional loss and maybe the grief and the sadness that goes along with dealing with taking care of a loved one. There's so many things they have to deal with that denial, in my opinion, is a coping mechanism that's serving them because they're not ready to go to an emotional place that is really, really hard and can be devastating. And I have to honestly say, very early on in my practice, 30 years ago, when I started my counseling business, if I stripped that denial before they were ready, it was a disaster. And that was a hard lesson to learn very early on in my career. And I am so incredibly respectful of that now, because I have a much better understanding that denial is protecting them until they're ready to deal with the emotional impact all of this is going to have on them.
Wow. Thank you. That's so helpful. I mean, people have their defenses up for a reason, and we need to respect that wherever they are. So thank you so much, Tammy. That was really great.
Yeah, thank you.
Yeah. So our final speaker is Paula Marks. And so Paula today is going to address anticipatory grief and how it plays a significant role in a spousal caregiver's perceptions and behaviors. So Paula.
Thank you so much, Amanda. Wow, just phenomenal, Tammy and Rob and Elizabeth. Just, so much information. Thank you so very much. So in conversations with my team, as well as with colleagues, it's clear that helping the spouse of a client who has dementia agree to and secure the level of care recommended by healthcare professionals is very, very challenging. While this has long been recognized, up till now, there's been no formal solution developed to address this. So over the course of the last quarter, I made a commitment to researching this phenomenon to tease out the issues and develop a solution so we can provide this much needed care more effectively. And to this end, I conducted 28 open-ended interviews with partners of individuals with dementia and other healthcare professionals, such as gerontologists, geriatric psychiatrists, multiple care managers, home healthcare professionals, and financial advisors, in order to kind of capture the issues and concerns presented by them in regards to securing needed dementia care. And full disclosure, this is not rigorous social science research. This is just VP of Care Partnership trying to figure out how to solve a problem. So some repeated and clearly identified issues concerning care reported from the spouse were a need for autonomy and connection, involvement in caregiving and freedom from caregiving, and the desire to be cared for as well as to be left alone. Moreover, the spouses implored that they want care professionals to know which need to address without having to necessarily explain themselves. From the vantage point of care professionals, the spousal issues identified as an obstacle to providing care were denial, sabotage, feeling overwhelmed, resistance to change in lifestyle, and additional psychosocial and physical issues. Irrespective of the issues identified, however, both parties agree on the same thing: the need for excellent dementia care for their loved one or their patient. So as you may have noticed, the needs presented by the partners were inherently paradoxical, meaning that they are often contradictory and competing, which of course alludes to the inherent difficulty care providers have when trying to assist them to secure care. The issues mentioned by the care providers themselves were singular issues that I will argue represent a manifestation of the unmet needs the spouses identified. And let me explain further. For example, when a spouse refuses recommended medical equipment, providers feel that they may feel that they are sabotaging care. However, on further exploration, it could be that the spouse merely needs a reprieve from the constant visual reminders that their home is now a care setting. And once that need is met, say, for example, through the provider taking time to research and purchase medical equipment that complements the house decor, the spouse may have less of an issue with the care in his or her home. And other examples are behaviors around how dishes are put in a dishwasher, or how an egg should be cooked, or how a table should be set. It's important for the provider to address how a need manifests, as this is the spouse's prerogative as a consumer of care. But they must further understand that the need to be met is to feel in control in a situation where the spouse feels out of control. By focusing on addressing the needs behind some of their manifestations, providers can effectively de-accelerate the stress of the spouse while simultaneously strengthening their capacity to collaborate with the spouse, affording better overall care. In a review of the literature around spouses and dementia, grief is a central theme. From this, I would argue that the antecedents for the paradoxical needs presented by spouses that makes providing this care to them so challenging is a direct result of stresses provoked by grieving. I would also argue that if providers approach spouses as if their needs are the result of grief, these needs would not be experienced as confounding, but rather understood as a natural part of the grieving process, and both parties could focus more on their mutual interests, thus reinvigorating the healthcare relationships. So in terms of grief, most of us are familiar with the Kubler-Ross model of grief that poses the 5 stages: denial, anger, bargaining, depression, and acceptance. And if everyone goes through these stages in unique ways and cycles, but cycling through acceptance is considered the goal of resolving grief. As we know, when grieving a non-dementia terminal illness of a loved one, there is ample opportunity to share feelings and resolve conflicts before their physical death. And this grieving process is widely acknowledged and supported. However, with dementia, there is little opportunity for resolution due to the declining cognition of the demented partner. So the spouse may feel that their loved one has already died emotionally, spiritually, or in relation to them long before the physical death has even begun or occurred. Thus, the grieving process in dementia can feel ambiguous or even guilt-producing, since the well spouse is grieving for someone who is still present. Moreover, since this disease can last for a decade or more, the spouse is in this ever-fluctuating state of grief for an exhaustively long period of time. Either pre or post-physical death, spouses of partners who suffer from dementia have more stress overall than those where dementia is not part of their experience. So in-home care for a couple where one has dementia and the other does not is a healthcare relationship. And like all relationships, it requires empathy, listening, building trust, and working together to a common end. While the parties to this relationship share the goal of retaining quality dementia care, one party is a resource to another as they are actively grieving the loss of the spouse. There should be no expectation of grief resolution for the partner, because as we know, that may come years after the provision of care has ended, if at all. What we can do, however, is acknowledge and support their grieving and provide the care that is needed. It may seem that all of this is too nuanced to implement as part of a business process, but at Tender Rose, we have done exactly this. All parties involved in care provision at Tender Rose receive training in dementia grief, ambiguous loss, and active empathetic listening techniques. We know and accept that we will be providing care to someone who is actively grieving, and that due to this, his or her needs will be organic, ever-changing, and potentially paradoxical. The implementation of this training allows the spouse to feel heard and Tender Rose the ability to tease out the needs to be addressed without getting caught up in the manifestations of these needs. To keep abreast of the pace of this care, we implement information gathering, communication, check-in, and escalation protocols in a well-documented and systemized way. So the exciting thing about these findings and all of the presentations today that have led to these protocols that I've developed is that all they really require is for us to be more humane and ensure that this is and remains the heart of what we do as healthcare professionals. So thank you.
Wonderful, Paula. Thank you so much. It's really great to hear kind of, direct feedback from all of the people that you connected with, to hear, what's really going on for them and how hard this is, and how we need to better support them through this. We did have a quick question. What do you do when your approach is unsuccessful, perhaps?
Sure. And of course it is. And sort of how, so many parallels, of course, in what I said with Tammy and Rob. And really what you have to do is just reconvene and reapproach. But what you do not want to do is force care on a couple situation. You really have to be mindful of playing the long game. What you are, in fact, is developing trust. And so, as was discussed previously, you might have most of us are involved with people who are in a crisis situation, and there's a lot of work that needs to be done. And, we're aware of that. But in order for that to be successful, you really have to stop and approach the case with a type of mindfulness where you're going to kind of have an incremental inboard and incremental acceptance and just kind of coming back at it and coming back at it and coming back at it. Unfortunately, that may mean that you might not be able to provide that needed care for a while. And that's just, the way it is. But the one thing that should not happen is to kind of drop the case, to be ever vigilant about keeping in touch and kind of tracking what's happening, talking with other resources that might be helpful to the couple and getting them the help they needed.
Great. Thank you, Paula. And thank you again to all of our presenters today. We have a couple minutes just for a few more questions if we have them. So if anyone, on the call has additional questions, if you want to put them in the chat, we can address those. We have a few minutes here. We have one final question that has come in for Tammy. And that is, at what point should you give up attempting to help a spouse to get care for their loved one? Or what does that look like?
Yeah, boy, that's a really, really challenging question. I think if you can establish some trust and alliance, let's face it, it's very heartbreaking when we can see what they may need and they're not ready to accept it. I just keep the lines of communication open. I let them know the last thing I'm going to do is try to shove my agenda down them, because it's not about me. It's about being respectful of where they're at. And if they're just not ready to be there yet, I get calls from people 2 years ago, 3 years ago, saying, oh my God, Tammy, I am so ready now. I understand what you were saying, either privately or in the support group. We have to be respectful. And if they're just not ready, again, I go from the perspective of they're not ready for a good reason. And the more I can understand the purpose the resistance served, the more information I'll have to understand where they're coming from. So I'm always going to honor that boundary. If it gets to the point where I'm not helping them or they don't feel a benefit by what I can provide for them, you don't cut your losses. You give them the space they need, the respect they need, the dignity and honor that this is just where they're at, but they always have my number. They always can reach out to me, and I just don't close that door. I keep it open.
Great. Thank you again. I think that's probably going to wrap us up. I don't see any other questions coming through. So
I think Dr. Sutherland?
Can I just?
Oh, I'm sorry. Yes.
Can I just want the great question about the abuse aspect that Rob was highlighting about. From a different perspective, you look at it with sort of like is this abuse new? Is the person with dementia, is it a new abuse? Is it something that's not their normal behavior? Because before you look at medications, you want to look at what's going on with this person and physically. You've got to rule out infections like a UTI, because that can really shift a person's presentation quickly. Are they constipated? Are they cold or hot? Are they hungry? Is their sleep askew? Is what changed and like what's changed in the environment? Is the caregiver changed? Is something going on in their home where they're moving or something's changed? So, you know, we just sort of want to tease those aspects out, because sometimes people are real quick to do, you know, pharmacological aspects to it, and that'll really shift things too.
Good point.
But I think that I always think about is how the person's communicating with the person. With they going too fast, they asking too many at one time, where the person is just physically looking at you and conceptualizing, where have I seen this person? Who is this person? And then we're saying, oh, how are you? How's it going? Are you hungry? Are you thirsty? Do you have to go to the bathroom? The person's like, oh my gosh, who is this person? So it's a lot of that. But you know, you guys are doing tremendous work. Being in this field is not easy, and you know, it's a definite love, and I can see it amongst you for being in this discussion and all.
Yeah, you definitely feel the passion come through. I mean, I think that's why we're all here, is that we genuinely, we want to make a difference. We want to be of service. So thank you again to all of our panelists. You guys are all phenomenal, and we're so fortunate to have you in our care community. Thank you to everyone who joined us today. We're so grateful that you took this hour out and hopefully learned some things that will help you be a better service to your clients and their spouses who are dealing with an awful lot. So we're going to be sending out an email tomorrow with a recording of this, just in case you want to watch it again, or we'll send it to people who weren't able to join, and also a brief survey if there's only 3 questions, if you wouldn't mind just giving us some feedback so we can keep improving, and we'll continue to host these virtual salons in 2021. So thank you again, everyone, and have a wonderful day. All right.
Thank you. Thank you for having me.
Bye.
Bye-bye.
Bye.